Good morning, everyone. First of all, I would like to thank you to the organizer for this opportunity to present some of our data. And I have divided. Can I have the presentation, please? I have divided my talk in two different parts. The first one is going to be related to the microglial activation in PS1 and APP models, in E-beta-based models. And in the second part, the talk is going to be focused on the microglial activation in real Alzheimer's disease, in samples from real patients from Alzheimer's disease. I have to mention first that this work has been done in deep collaboration with Dr. Antonia Gutierrez here from Malaga. So concerning to the general opinion about the neuroinflammatory response in Alzheimer's disease, the general thought is that the microglial cells could display a pro-inflammatory role, releasing several mediators that could indeed contribute to the progression of the Alzheimer's disease. This general thinking is mainly based on the work done by several important groups in the world using I-beta-based models. And indeed, also in our hands, the microglial response is very clear, or you can see a very clear response of the microglial cells since the first deposition of A-beta plaques. These microglial cells respond increasing the expression of many different molecular markers and also changing the morphology surrounding the E-beta plaques in the parenchyma. These microglial cells, these active microglial cells, present some phagocytic capacity. This phagocytic capacity of E-beta could be observed even by confocal immunohistochemistry or in vivo assays by injecting methoxy OX4 in vivo. Importantly, in the models, the microglial activation is exclusively observed surrounding E-beta plaques. As you can see here, by regular immunohistochemistry or even by EM, the macroglial cells in the models are always located upside of the plaque. Indeed, the A-beta plaques are made by a dense core of E-beta, condensed E-beta, and the macroglial cells are always surrounding this dense core of E-beta. We have never observed in models any prolongation of macroglial cells inside of this core of beta in the plaque. The scenario changed a little bit when the models age, in the sense that at early ages, like a 6 months or 12 months of age, the macroglial activation is restricted to the beta deposition. However, when the models became older, like 18-month-old, we can observe a generalized microglial activation, not only restricted to beta plaques, but just in the whole parenchyma of the hippocampus, of the hippocampal formation. These active microglial cells display a classic phenotype expressing many pro-inflammatory cytokines. This generalized activation of the microglial cells is due to the deposition, not the beta compacted in plaque, but the deposition of soluble E-beta species. These soluble E-beta species can be purified using specific anti-oligomers antibodies. There are many different oligomeric forms exclusively at late ages, and this soluble A-beta could stimulate the microglial cells in vitro. These stimulated microglial cells in vitro display a mixed phenotype, M1 pro-inflammatory and M2C anti-inflammatory phenotype. This pro-inflammatory phenotype of the microglial cells could be due to the recruitment of monocytes or macrophages from the peripheral or from the periphery. Indeed, it is very hard to distinguish from the molecular point of view or from the morphological point of view between a monocyte or a microglia. However, there is some specific markers to each population. These specific markers are CD45, CD68, CCR2, or the fractalkine receptor 1, or the purinergic receptor 12. The first three are specific for the monocytes, and the two seconds are specific for macroglial cells. In our models, we did observe an increase in the expression of all markers specific for the monocytes and a decrease in the expression of all markers specific for microglial cells. So this result or this data could be interpreted as a recruitment of monocytes inside of the cerebral parenchyma. However, in vitro, primary microglia or even macroglial-derived established cell lines also reproduce this phenotype when active. As you can see here, LPS indeed increased the activation of the microglial cells in vitro, and this active primary microglia also overexpress CD45, CD68, CCR2, and decreased the expression of the specific markers from microglia. Therefore, we have absolutely no evidence for the recruitment of monocytes from the periphery inside of the cerebral parenchyma. However, in our models, we did observe a clear lymphocyte infiltration. We did observe an increase in the expression of specific markers for lymphocytes, like a CD3. Also, this lymphocyte could be observed surrounding, in some cases, A-beta plaques. And interestingly, these infiltrating lymphocytes express an anti-inflammatory phenotype, a Th2 anti-inflammatory phenotype, overexpressing interleukin-4 and TGF-beta1. We tested the role in the models of this infiltration of lymphocytes. To do those experiments, we knocked down the expression of interleukin-4 and crossed the knockdown model with PS1 or with APP transgenic mice. We did expect an increase in the inflammatory reaction, as you can observe here, and also, and interestingly, we observed an increase in the AD pathology. We did observe an increase in the A-beta accumulation. We also observed an increase in the A-beta extracellular A-beta deposition, and we also observed an increase in tau phosphorylation and in neurodegeneration. Therefore, as a conclusion of this part, the macroglial response is very clear in models. It is restricted to A-beta plaques at early ages. It is generalized in the whole parenchyma at late ages, and modulating the Th2 response of the lymphocyte could aggravate the progression of Alzheimer's disease. In conclusion, in models, at least in normal hands, the microglial response could indeed mediate the progression of the AD pathology. So, in the second part, and based on what we know about the microglial response in models, we start characterizing this response using human samples. These human samples come from the with a gift from Dr. Ferrer and Dr. Rábano. And there are many open questions about the microglial response in Alzheimer's disease. Some of them are in this picture. And the first one is if the microglial cells are prime in the sense that could be partially activated with aging. Also, of course, we don't know which is the role of the microglial activation in Alzheimer's disease, and even we don't know if these cells are implicated or not in the progression of the pathology. Concerning to the first questions, the general opinion is with aging, the microglial is already prime in the sense that acquire a proactive status in which these microglial cells respond more strong to a second activation. Once again, these propositions are based on models. Therefore, we start our characterization by testing if the microglial cells are prime or not using human samples. For this aim, we just compare young controls around 50 years old with no pathology with BRCA2 individuals with 84 years old of media. And we start just characterizing the molecular profile of these samples, looking for microglial activations. And as you can see here, I'm going to know in detail about this busy figure, but you can see the profile is not different at all with controls. So at least from the molecular point of view, there is no significant difference between BRCA2 samples and controls. Moreover, for the morphological point of view, in our cohort, the microglial cells seems to be totally quiescent or resting in the sense that they are perfectly ramified with a small cell body. Some cells usually align around the apical dendrites of the pyramidal cells. More interestingly, these cells are somehow ordered in the hippocampal parenchyma, and in fact, the area covered by these cells are distributed in some normal distribution. As you can see here, the microglial cells cover around 30% of the parenchyma. This is the peak of this normal distribution at the dentate gyros of the hippocampus. You can argue that maybe the microglial cells or the morphology of the microglial cells in human is different from models. And maybe these apparently resting cells are indeed activated cells. However, when active, these microglial cells are clearly distinguished from the resting morphology. This is a particular case, is a control case, 30 years old case with apparently no pathology that exhibit a very clear inflammation. As you can see here, these microglial cells are rounded cells indicating a very clear activation that is visually different in morphology from the BRCA2 microglial cells in our hands. Therefore, at least in our cohort, we have not observed, never observed, such a prime state status in the macroglial cells. Maybe, we cannot discard, of course, that prodromic Alzheimer's disease could indeed, or could have a different phenotype. You should remember that this cohort is a postmortem cohort, it's just a BRCA2 individuals with no pathology at all, just some tau deposition at the endorenal cortex. Okay. Concerning to the second question, which is the role of the microglial cell in the progression of Alzheimer's disease, we extend our observations not just to control and BRCA2, but to BRCA3, 4, and BRCA5, 6 individuals. All of them have more or less exactly the same age, except in the normal controls. As far as we know, because we have not much information about the natural history of these samples, of these patients, the only population that have dementia is the BRCA5, 6 cohort. Therefore, we assume that, yes, this population is the Alzheimer's disease population. So we first tested which are the molecular pattern of these different samples, looking obviously for microglial activations. And the first difference we observed with the models is that the expression of many different markers of microglial activation are more or less similar to, or there is no very clear differences between controls, BRCA2, BRCA3, 4, or BRCA5, 6. There is just a small increase in the expression of many of these markers exclusively in the BRCA5, 6 population. Therefore, the microglial cells could be active just in the Alzheimer's disease population. These active cells could be visualized by immunohistochemistry using CD68 or CD45, and these active cells are grouped probably around or surrounding A-beta depositions. Since the increase in the expression of the molecular marker we observe are exactly the same as the monocytes, we wonder to know, or we wonder whether there is an infiltration or macrophages or even monocytes inside of the parenchyma in the BRCA5 or 6 population. Trying to discriminate between active microglia from monocyte, we measure the expression of two more markers, a specific marker from monocyte, like CCR2, P2, RX4. Those markers are specific for the monocyte population. And we did not observe any correlation between activation and a specific marker for the monocyte population. Moreover, we test the patrolling monocyte population using the mannose receptor 1, and as you can see here, the expression of this marker is exclusively restricted to the perivascular space. And we did not observe any infiltration in the parenchyma. The same is true for the CD45 high expression. This is restricted to the vessels, and we did not observe any infiltration to the parenchyma. Concerning to lymphocytes that are obvious in models, we did observe a very small, or very few infiltrated lymphocytes restricted to PIAL or PIAL areas of the cortex. The second difference between models and human, Alzheimer's disease human, is the localization of the microglial cells in A-beta plaque. These pictures come from a patient with BRCA3, 4 pathology, and as you can see here, there are many microglial cells exhibiting A-beta inclusions inside those cells. And those microglial cells are located not surrounding A-beta plaques, but inside of the A-beta plaques. The presence of these microglial cells inside the plaque could also be observed by confocal microscopy. And interestingly, we can make, this is a hypothetical progression of the A-beta plaque. This is not real. These are a picture taken from the same individual with Bradford pathology, in which we try to correlate the deposition of A-beta and the position of the microglial cells. As you can see in the first slide, there is some, it's hard to see from here, some diffuse A-beta and some microglial cell exhibiting A-beta inclusion inside of the cells. Then the pathology could progress, this is theoretical, to a more fibrillar A-beta surrounding and containing A-beta containing microglial cells. Then we also observe fibrillar A-beta surrounding by microglial cells containing A-beta and or presenting microglial cells inside. And finally, you have a compact plaque, A-beta plaque, that indeed has microglial cells inside, just changing the colors in the immunohistochemistry, that totally differs from the position of the microglial cells in models. In models, as I mentioned before, the microglial cells are always surrounding the A-beta plaque. In humans, the plaque are made, or the microglial cells are inside of the A-beta plaque. Also, when we were characterizing the microglial response, we, of course, determined the expression of the fractalkine receptor specific for microglia and the purinergic receptor 12 specific for microglia. And we did observe not an increase, but a specific decrease in our BRCA5/6 population. This decrease in the expression of this specific marker for microglial could be also observed by immunohistochemistry and could be assessed quantitatively by quantifying the purinergic load. And we did observe a generalized decrease in the BRCA5/6 population in the expression of this marker. However, we also find that the expression of these two markers, fractalkine receptor and purinergic receptor 12, decrease when the microglia is active. As you can see here, the resting microglia is, the expression of IBA1 and purinergic receptor 12 colocalized in resting microglia. However, the expression of the purinergic receptor is vanished in active cells contacting to A-beta depositions. So, the purinergic receptor 12 is not a good marker to see if the microglial decrease or not, because the expression is changing with the activation. Therefore, we made the same experiment using IBA1. IBA1 is a specific microglial or monocyte marker that which expression didn't decrease with microglial activation. And as you can see here, as in our population, you can see using this marker a very clear degenerative status of the microglial cells in BRCA3/4 and a dystrophic status in BRCA5/6, or even absent of the microglial cells in the hippocampal formation on these samples. Of course, this dystrophic or even absent of microglial cells in humans have never been observed in models. Models, the microglial population is there, and even on all ages, even increase in all ages. To be more quantitative, we quantify the density, the numeric density of the IBA-positive cells in the dentine gyrus, the polymorphic layer of the dentine gyrus, and we did observe a decrease, a clear decrease in BRCA5/6 samples, but just in half of the population. From 8 cases quantified, We observe a decrease in 4 cases with no changes in the other 4. However, we also quantify the IVA load. IVA load represents the area covered by IVA-positive cells. And in this particular case, we did observe a more generalized effect. We did observe a decrease in the expression, in the IVA load, principally in the dentate gyrus. Not in all cases, in 7 from 8 cases, there is one of them that is not changed at all. There is a decrease also in CA3, less evident in CA1, and not significant in cortex. Similarly, in BRAC3-4, we did observe a decrease, exactly with the same pattern in 2 cases from 5 tested, and none of them changed in BRAC2 population. In consequence, this is, we can postulate the existence of a specific degeneration of the microglial cells in dentate gyrus, less affected CA3, less affected CA1, finally, less affected in cortex. Of course, this degenerative process also changed the microglial domain we did observe very clearly in BRAC2 samples. As you remember, in BRAC2 samples, the microglial cells are more or less evenly distributed in the parenchyma, covering approximately 30% of the brain area. However, in Alzheimer's disease samples, the peak clearly shift to the left, just covering half of the brain parenchyma in these samples, just 14%, also following a normal distribution. However, in intermediate states like BRAC3 and 4, we observed 2 peaks. One of them could be normal, and the other one just corresponds to the degenerative status of the microglia. Furthermore, independently of the quantitative data, we did observe in BRAC5 and 6 cases very often dystrophic microglial cells. Dystrophic in the sense that the microglia has no prolongation. Also, they could have cytoresis, introduction of the cytosols, and clearly beating dystrophies in these microglial cells. Following the same schema as before, this is the normal response of the microglia in non-affected samples, non-affected individuals. We can propose that when the beta plaque is made by the microglia, perhaps, the microglia degenerate around plaque. And it's very frequent to observe in BRAC5 to 6 many different A-beta plaque with absolutely no microglia inside or surrounding the A-beta plaque. This observation is quite clear at the presubicculum. At the presubicculum, you can see the position of A-beta just in the inner molecular layer, on the inner layers, and no A-beta depositions in the outer layers. And as you can see here in detail, in the outer layers, the microglia seems to be normal. This is a BRAC5 to 6 individual. However, in the deep layers, the microglia seems to be totally degenerating. Same effect is observed, from this observation, we can conclude the A-beta could be toxic for the microglial cells. However, at the hippocampal formation, the polymorphic area is the most affected region of the hippocampus. However, in these polymorphic layers, there is very few, if any, A-beta deposition. So, A-beta could be toxic for the microglial cells, but there is toxicity without A-beta deposition. So as a conclusion, I think the more relevant conclusion of this talk or observation is that the microglial response to observing A-beta-based models just partially or maybe deficiently reproduce the immune response in Alzheimer's disease. We did observe in human cases that microglials or macroglial cells could be implicated in the A-beta formation, the beta plaque formation, and also we did observe that hippocampal formation, also in another different areas, the microglial cells could undergo a degenerative process. The reasons of this degenerative process or the toxic agent that produce these microglial degenerations are, we already work to see which are the toxic agents that produce these microglial degenerations. Okay, thank you very much for your attention.